from Pune, from Delhi. So we're going to briefly talk about the role of arthroplasty, like a CME model. Like we're going to talk about the hemiarthroplasty, total shoulder replacement, as well as reverse shoulder for trauma, which is more relevant practice now, and also about the reverse shoulder complication. It'll be like educative more, and we'll take panel discussion at the end. First of all, the evaluatives as a company, they wanted me to also talk about the use and practice of shoulder arthritis and the role of elective surgery in COVID-19 scenario. So I will just start off with my brief lecture about that condition in perspective. Share screen now. Okay, it's okay. Can you see the PowerPoint?
Yes.
Yeah.
Okay. So arthritis in the COVID times. This is a webinar done last week when we talked about the practice of orthopedic surgery uh, in this scenario. Dr. Jitendra Maheshwari put up this elegant slide, shows the changing practice post. Can you please unmute everyone except me? There's a lot of background noise. Could be. No.
Yes, sir, I'm doing that.
Okay, thank you. So this is a slide shown by Dr. Jitendra Maheshwari in the last basis webinar, and it shows very clearly our practice is changing post-COVID era. We cannot go back to the same situation as like before. If you fall sick or you need a doctor's opinion, you straight away go to the doctor before. But now you are trying a home remedy or trying online consultation. Same way, if you're doubtful about operating or conservating, you go for operation. If you decide about operation, go quickly, have it done, bang, bang. But it's not going to be the case now. You're going to be trying conservative first and then delay operation as much as possible. So that's the first highlight, and that's the second highlight. So these are the changes are here to stay. So let's talk about the first one. Comes the role of telemedicine or telerehabilitation to treat our arthritic patients. So this has been really approved by Medical Council India. It's got a clear guidelines published on the day of lockdown starting. The guiding principle is professional judgment. You have to exercise to professional judgment to decide whether the teleconsultation is sufficient or a direct in-person interview is needed, and you consider the 7 elements. First is the context, whether it is okay to go ahead. Second, identification of both yourself as well as with the patient, because we're not seeing directly each other. Use the best mode of communication. The consent is implied if the patient calls you, and ask for test if you need. There is always maintain a record of digital trial and document, and also manage the patient. For training to arthritis, you could recommend physiotherapy, stretching exercises, prescribe painkillers, but you are not allowed to prescribe narcotics, morphine, codeine-based medication, psychotropics, or tramadol. This is recently added on. Some psychiatry practice drugs like phenobarbital, clobazepam, and clonazepam have been allowed to use. Maybe they're showing the way the public is going towards getting depression, etc. My tips for telemedicine online consultation: preparation is the key. Use a laptop with Wi-Fi connection, not a cell phone connection. Use a dedicated platform rather than using WhatsApp or Zoom platform, because it will provide video, audio, chat facility. Checking ID and consent is automatically done by the software. Record of log is done, and the consultation document is ready at the end of the consultation to be sent to the patient. Always maintain a professional appearance and the background. Basically, we want to simulate as though it is a realistic consultation. If you want to assess the movement of the shoulder, for example, because it's not a chat to chat mode, so you have to ask the attendant to hold the camera and give clear instruction. And modify your exercises as per the available equipment at home. Reinforce the key point at the end of consultation and give some time to ask question, because they will not be able to come back and ask a doubt. Provide resources, link, etc. like YouTube videos. Give a home exercise sheet as a PDF file and have some follow-up mechanism. Now, what about shoulder replacement as a surgery in COVID times? This is a clear-cut guideline from Indian Orthopedic Association, which why we have to modify orthopedic practice. We cannot practice the way we were doing before for obvious reasons. And the patient triaging for surgeries is very important. We have to minimize admission for inpatient care as much as possible, avoid routine surgeries, that is a classical description by IOA, use healthcare resources wisely, triage patient with higher tendency for non-operative treatment, and avoid surgeries in geriatric or patients with comorbid conditions. The risk is to the patient mainly one is cost expenditure, second is risk of COVID exposure, third is the higher chance of mortality, morbidity. This is based on this paper which shows 34 asymptomatic patients developed COVID infection, 44% ended up in ICU, 20% died. So they are very susceptible in the hospital environment. Example, older patient, comorbidity, complex surgery were risk factors. But if you look at the shoulder replacement for arthritis or cuff arthropathy, they fall in this category automatically. They are older, they have a lot of comorbidity, and the surgery may be often complex, taking few hours. And also, any replacement surgery is an aerosol generating procedure, reaming, all these things have to be taken into account. Second, but what the proponents who started to practice early say, pain and disability to waiting patients, decline in health, more vulnerable to infection. These may be applicable for some hip arthritis or debilitating condition of spine, but not applicable very much to a shoulder or upper limb problem. And they say patient wants surgery now because they want to recuperate in the lockdown period of whatever remaining period. But we have to know the warning. We don't know how long the pandemic lasts. We don't know exactly where on the curve we are. The curve should be going downhill, down, and then we have to give sufficient time to reduce the risk. Mind, we are exposing very vulnerable population to the risk of infection. And then we are utilizing a lot of resources which might be very important in the future, we don't know. And there are risks to the patient, attendant, staff, and surgeon. Most importantly, staff and surgeon, because that we have to take care of ourselves first. This is the published study of 26 surgeons in 8 hospitals in Wuhan, and it shows the spread mostly occurred in the general ward or OPD situation than in operation theater. Maybe the fact that in operation theater we usually take more precaution. But story never ends there. So this example, we have 3 deaths recently. Is Lakshmi Narayanan, orthopedic surgeon from Nellore. Simon Hercules is a neurosurgeon of a private hospital in Chennai. And Sisri Kumar Mondal is an orthopedic surgeon who recently passed away in Kolkata. These are the orthopedic and neurosurgeons who had met with death succumbing to COVID infection. So had to be careful. How to, on this basis, I just encountered this paper, which is published recently, editorial in patient safety in surgery, how to risk stratify elective surgery during COVID-19 pandemic. This is the emergent procedure. Had to be done less than 1 hour. There is no doubt we have to do that. Compartment syndrome comes in here, this category, or vascular injury. Then you have an urgent category. Within 24 hours, operation should be done. That's an open fracture, and the femur shaft fracture and hip fracture, they take priority. Third is urgent elective, should be done usually within 2 weeks. It comes here, all the closed fracture, which can safely wait if we can. Then comes the elective essential, range 1 to 3 months here. If you wait, the time delay might affect the outcome. So, and the elective discretionary, where there is not a time-bound change in the outcome, there comes the joint replacement and sports injury. So that comes the arthroscopy and the arthroplasty practice for us. So elective discretionary, purely elective procedures that are not time sensitive for medical reasons. In that criteria, we have shoulder replacement for arthritis and cuff arthropathy and sports surgery. Shoulder replacement where it has to be done for a locked fracture dislocation or a floating shoulder is different category because that comes under trauma urgent surgery. So they devise an algorithm, but basically it says whether your facility has the capacity and capability to manage, or is it compromised? Is there a patient, a high risk patient in terms of symptoms or contact? Or the patient high risk personally, ASA grade 3 or above, or has got additional risk factor like elderly age, COPD, or chronic heart failure, asthma, etc., or immunosuppression. If you have all these criteria, then please avoid it. Please cancel and reschedule. We have only one suggestion, American College of Surgeons guideline, but it does even say hospital or health system or a surgeon should thoughtfully review. So the onus is on the surgeon or the hospital. And there are 10 issues to talk about. I've just briefly mentioned this. Number one, we have to know the status or statistics of your local community corona affection. Not any part of every part of India is not same. Second, you should have a clear-cut COVID testing policy of the patient, what test you are going to do. For the attendant, what test you are going to do. You have to restrict the attendance, and you have to do the COVID testing for the surgeon and the staff. Full PPE precaution, as Nandan was highlighting here, you had to make sure that you are using original N95 mask. The institution's capacity and resources, whether you can operate and go, but the patient has to be using a lot of resources like ICU, post-op, that should be available, they should not be mixed up. Supplies chain, because they have been also shut down for a long time, so they have to have some time to get the prosthesis, and you might not end up compromising the quality of the surgery. Healthcare worker staffing, some contingency plan for absence and sickness should be there. And you had to have some sort of local group inside the hospital to look into these issues and act on. Patient communication and inform the concerned regarding the risk of COVID infection to them, and then they would not hold the hospital or the surgeon accountable for any spread of infection to them should be obtained. And you have to prioritize surgery based on the criteria which have been described before. And you have to maintain safety in all phases of the patient stay, either pre-op, anesthesia, intra-op, post-op, and follow-up, and minimize the contact as much as necessary, possible. So we had a message from Cormac Kelly, and he said, hi, great that you kept this going. I hope to join the webinar. My question is there any shoulder elbow condition that cannot wait 3 months for surgery? My answer is only one: progressive compressive ulnar neuropathy. I think that explains you the situation for shoulder replacement too. Thank you.
Thank you, Ram.
Okay.
Ram,
yes.
can I ask you a question?
Yes, please.
If you were to have done surgery in this awkward times, during surgery, what precautions would you advise our colleagues?
During surgery, number one is that full PPE precautions for all the staff and the nurses. That is the key, because when initially 2 weeks ago we were doing like regular use of theater mask and cap and stuff like that, but here now at this stage it is no longer included. That is number one. Number two, avoid surgeries which involve like much aerosol creating, which is actually reaming, reaming using the saw. So that sort of procedures have to be minimized. And the third thing is during anesthesia, the anesthesia type also different. If as far as possible, try to do the regional block and avoid general anesthesia per se. If you could do that, for example, an elbow, wrist, hand condition, or even shoulder, it can be done in the block. That can be also employed. Fourth is about the laminar flow. There is some plus and minus about talking negative pressure, etc. But it makes you very uncomfortable to do that without laminar flow. So I let the laminar flow on. I just want to know what you do, or what is your thought on that?
Well, two things about the block. I think that can be a little dangerous, because if the patient is a COVID patient, if he is not a COVID patient, then it's okay. But if he coughs and sneezes during surgery, then as a shoulder surgeon, we are right next to the line of fire, and anesthetic is also on the line of fire. So from that point of view, I would prefer a general anesthesia, really speaking. If he had COVID-19 infection and his lungs were compromised, then it makes sense to avoid further trauma to the lungs, is my contention. Raman?
Yeah, Ashish, just because yesterday we received something like a consensus on orthopedic surgery from, I think, somewhere in the US, where 38 people had given a consensus, and it's a very detailed one. I'll share it on the shoulder think tank or on the SESI group. But there were a couple of things. The only two things which they said important was if the patient has been tested before, and it's not a COVID-19 patient, or you say it's a suspected patient, So in that scenario, they are recommending sealing of the eyes. So goggles, I'm trying to see what all constitutes a PPE. So goggles which seal off the eyes, and N95 mask, and a wrap around the neck which goes into the gown. Into the gown. So I don't know. So we thought of using the surgical hoods like we used to do in the Chanle type of suits, Ashish, in Wrightington, you know, and we've got these exhaust pipes. So one of my colleagues was operating yesterday. He had to fix a fracture femur. And you know, this machine, the pump got malfunctioning during the surgery. So he got all
suffocated.
Everything suffocated. So I read about these surgical hoods, and in fact, they have been discouraged now in that consensus. So don't use surgical hoods, just use a wraparound which can go into the gown so that everything goes in and not out, and maybe N95 and goggles sealing of it. That should be more than enough. And maybe one gown or two gown, disposable gown, because not all hospitals have got the so-called PPEs, which are jumpsuits and how much GSM. So there's a lot of confusion, and hospitals are not buying those PPEs as well.
I don't think we need all that.
No.
Our surgical disposable drapes and gowns are impervious.
Yeah.
So that is all you need. You just need to take the above the shoulder part and ensure you're closed. And if you don't have a goggle, because somebody like you and me who wear specs, it's difficult to wear eyeglasses because we will not be able to see well.
So what would you do?
So you wear a visor.
Visor,
You get a visor.
We got that.
There's a face shield that can be close to the.
One important point we had to think about when talking about general anesthesia is one protocol which we have added into our hospital is to actually get CT of the chest for all patients, because sometimes even blood tests are not very useful.
Correct.
Tests are not
that's a very good point.
That's one point.
You're right.
The preoperative evaluation, we need to do that. And in CBC, always look for lymphopenia.
Yeah.
That's the second point. And third thing is, when the anesthetist is anesthetizing, you're better off anesthetizing in a different room and then wheeling the patient into theater. So that will reduce the risk for most of the staff. And when you're doing the surgery, as you said, an eye cover, a hood, a normal surgical hood, not the one with a pump. The one with a pump is not practical, and they're a little bit discouraged. Normal surgical hood with a visor on and a double mask, and wear a plastic apron underneath your gown.
Okay,
The biggest problem with all the PPS coming into India, especially the ones we are seeing, the quality of them are very poor. And you think you're wearing a PPE, but actually you're putting yourself at risk. Because most of these are not at all water resistant. If you pour water onto them, they're actually leaking through. So I would suggest a normal gown with a plastic apron and a shield on top. And when you are extubating again, you go into the room where you have anesthetized him, and then extubate in a different room. That way we will reduce the thing. And all the dress you have used for the patient and yourself, you degown in the same theater, clean the theater, leave it free for 20 minutes at least if laminar flow theater, and then start your next case.
That's very important.
Somebody has asked, why is government not doing compulsory COVID testing for all patients that are coming in for surgery? I don't think that is mandatory, because if the patient is in the prodrome, those tests are going to be negative anyway. And you have to treat every patient as COVID-19 positive.
I think
because in the Wuhan study, they had incidentally picked up, even in England, that they came up positive much later. Thirdly, if you look at the percentage of positive cases in India, is less than 5%. And in America is about 12 to 20%, which means that possibly the technique of taking the swab is wrong, because it is a very didactic technique of taking the swab. It has to be from the nasopharynx without touching the turbinates. And so it requires a little bit of expertise. The medical people, Ayush workers on the streets will not be able to take it diligently, and certainly not in the mass numbers. So just treat them as positive.
Yeah, absolutely. I agree with that, Ashish. The one important thing we have to think about is, as Ram mentioned in his talk, we have been very regimental in how we do our theater stuff, but we are not as regimental as when we're doing our ward rounds and when you're doing your clinics.
Yes,
I think that is where we have to be more regimental rather
absolutely.
than in
And,
Yeah,
theater.
and
yeah,
the risk
That
is
Wuhan
higher
study
in,
actually proved that.
yes, the risk is much higher in the public or general ward area where you'd be a little bit careless, would not be taking exact precaution as in theater. Uh, okay. Uh, I think we have to consider everyone as a
Positive.
COVID suspect only. There is no COVID positive, negative, and all. We have to assume that he is positive.
that's right.
Okay. If there is no other questions on this topic, we will just move to next topic by Ashish. Okay.
Sure.
Is about the shoulder hemiarthroplasty catching a falling knife. Thanks, Ashish.
Thank you very much, Ram and Evolutives for making this possible. I have spoken on shoulder replacement and hemiarthroplasty probably thrice in the last 3 weeks. So don't want to repeat myself. Having said that, there will be about 5, 6 slides that I can't avoid reiterating, which is a good practice to reinforce the same points again and again. I know there has been a sustained requirement, demand, request from a lot of fellows about the tuberosity repairing technique. So I've included that. Not possible to do the entire technique because that will be time consuming, but I will do that in the next talk to show something new next time. But I will include the repair technique in this. Um, Catch a falling knife is because hemiarthroplasty has got a bad name. There are many reasons for that, and we ought to understand why. And number one, we have to be very careful, and we can't take shoulder replacement casually. I don't think it is mandatory that everybody should be able to do a shoulder replacement. Unfortunately, the seriousness of the shoulder replacement is not uh, taken up by a lot of the orthopedic surgeons. There was a discussion yesterday on our think tank group that these kind of cases should be done with people with experience. You must gain experience, and you can gain that in the cadaver lab or in your fellowships because it is a you get only one bite at the cherry. You can't say that, oh, next time I'll do a better job, and the results in expert hands are also suspect. So what I'm trying to say is that we must first know which patients need hemiarthroplasty. We have to be very diligent and not be willy-nilly offer everybody which looks like a difficult case, let me do a hemi. There should be very clear-cut criteria. And the results of hemiarthroplasty across the board are not the same. So there are countries like France and Germany who have almost given up on the hemiarthroplasty and they largely leveraged on doing reverses for most patients. Although the young patients then, England will actually prefer to treat them non-operatively. And I think that's not such a bad option at all, rather than make it difficult for, because the hemis that go bad are very difficult to salvage, very difficult. So you must understand that, keep the patient in the center and understand that there's a reason why these come in. So let us understand which hemis are to be offered to which patients. So definitely the elderly you should consider, but not the far elderly. So we are talking about between the age group of say 55 to 65 in very severe four-part fracture dislocations. When you're talking of elderlies above 75, then they probably do not qualify for hemiarthroplasty. And then we are talking about reverse shoulders, which the next speakers will take over and do a diligent job in explaining how to go about doing a reverse for fractures. It has to be a one-stage solution. You cannot say that let me treat this with plating, and if it were to fail, then I would offer him a hemi, because that doesn't work. And we must understand there's a huge role for non-operative treatment, which is pretty much neglected. And there's no harm in treating somebody without surgery and letting him settle, rather than have surgery and then revise that with the second surgery, which will never give you the same results. So sometimes there are fractures where the head fragment looks doable. It looks like a 2 and 3 part, and I've done this before where I look cocky and confident, go in, and the head is basically a mushroom or eggshell where the inside is very soft, porotic, and it's impossible to put in a plate fixation. So You can't make a silk purse out of a sow ear. So if you think this is a situation, this will be usually a situation for the very elderly 70 plus. The young patients are usually, my inclination is to treat them with a fixation and plating or a conservative treatment. The point is, if that were to occur, that you go in and you find that the head is fragmented, it is split, and we were unaware of this, then you must always have a hemi on the back table. There's no point saying that I did a fixation because I had nothing on hand. So that's a failure of planning. And for failure of planning, the first thing that a surgeon must understand is don't rely on X-rays, and certainly don't rely on AP X-rays. So all our patients will, as a sequence, get a true AP and an actual X-ray. You must have orthogonal X-rays. Number two, they will all have a CT scan. And on the CT scan, it has to be a 3D reconstruction CT scan. Actual CT scans are not enough. They're not giving you the information that you want. So once you are armed with the information, then you can sit down and see, because it is very easy to confuse a head split fracture where on the x-ray it looks okay and you go inside and then you find a head split, and then it's tedious because you're caught between two surfaces. Um, Typically, the four-part anatomical. By anatomical, I mean when the fracture line is not at the surgical neck of humerus, it is at the anatomical neck, which means that you have a much smaller head fragment available for your screws to purchase in. You must understand that on average, we will be putting 40 screws for these patients, lock screws in the proximal fragment. Of that 40 length, I would need at least 20-25 in the head fragment. If your head fragment itself is 18 which would happen in an anatomical fragment, and since as a rule I keep my screws 10 short, it's inconceivable that I can have an 8 thread screw in the head fragment and it will hold in place. On day one it might, but progressively it will go into varus and fail, and we'll end up having egg on our face. So be careful about that. The lock plate has made things very easy for us, and that's why it appears that we can recklessly go in and fix every kind of fracture. That's not true. You have to be very well planned and a good trauma surgeon to be able to capture all the head fragments, and especially the GT and LT fragments. Patients, when they come in late, and they often do in this country, if they come in at 2 months with a four-part fracture, then it's going to be very difficult because the scarring, fibrosis, the fragmentation, and osteoporosis will preclude a good form of fixation or purchase on this. So do be careful. I'm not too fussed about vascularity. If you take care of the ascending branch of the medial circumflex, which runs through the bicipital groove, and avoid using cautery in that area, and invariably the posterior capsule attached to the head fragment, that brings in a lot of rich blood supply. So even if you have a transient AVN, they should recover reasonably well, and it's unnecessary to revise somebody for an AVN if you've done a good job. You can see the X-ray on this side, everything is done well, cemented beautifully, aligned well, but the GT is missing completely. So once the GT is gone, it is game over. So you could have done a fantastic job on every front, having planned it, done a CT scan, executed deltopectoral approach, positioned the prosthesis, alignment, version, and cementing also. But if the GT is not in position, it is all or none. It is not going to work. So we have to invest all our talent, all our planning, all our execution in ensuring that the GT and LT will sit in place, and eventually, even if they do, they've got to heal. So that is very important. A lot of that has to do with understanding 3D anatomy of the shoulder, understanding what is the native version, understanding techniques of trial reduction and soft tissue soft tissue balancing. Offering a hemiarthroplasty for a fresh fracture and offering a hemiarthroplasty for a late 3-month-old malunited or failed fixation fracture is completely chalk and cheese and not the same. The results also will not be same. Can I request all the attendees to mute their phone? There's a lot of background noise coming in. Thank you. There's somebody in Gujarati with their mic on. Can they mute their entries? So this is one of the sides I keep repeating here, that there are no landmarks. Doing a hemiarthroplasty for elective osteoarthritis and doing a hemiarthroplasty for trauma is very, very different. The You have to understand that because there are low landmarks, the chances of making mistakes are very high. So often the biceps groove is not there, biceps is dislocated. Even if it is there, it's a poor landmark. Murchovsky's study said that the uh, prosthesis can be kept, the neck of the prosthesis should be at 5.6 centimeters above the superior border of pec major. But there are at least half a dozen studies which have proved Murchovsky's study wrong. It's a, it's a good metric, but it's not a perfect metric. So I use it as an ancillary metric to confirm that yes, my height of the prosthesis is good, because one doesn't know where the neck of humerus has been fractured. Whereas in elective cases, the surgeon will electively choose his resection level as such. That luxury is not available in trauma situation. Do be careful. You have to make every effort to find out whether axial nerve is involved or not. Because if you do a hemiarthroplasty in the presence of an axial nerve palsy, it is going to be a nightmare scenario, and medical legally will create a lot of issues. So when you have a split head, 4-part fracture is coming 6 weeks late, and you put this in, your findings that you need to look for here on a post-op X-ray is that number one, you have cemented it adequately on both sides. It's a complete whiteout. The cement has closed down there. You have a plug there. The Gothic arch, which is the Shenton's line of the shoulder, has been recreated well. The stem is along the axis of the shaft down the fairway. Your GT looks like it belongs there. It's in anatomical position, and it has to be at least 8 mm below the apex of the head, and the head should appear centered on the glenoid. If you have all these features, then I think at least on day one, you've done a decent job, and wait for the head tuberosity to integrate. Pascal Boileau's study created a lot of furore in this group, and suddenly surgeons became aware that hemiarthroplasty may not be a good option because the tuberosities do disrupt. Leading surgeon, very famous, very capable surgeon, but even in his hands, 23% patients had detachment of tuberosity even after initial correct positioning. And that would mean that it is over. The results cannot be adequate at all. So it's an all or none phenomena. But what I'm trying to draw your attention to, don't freak out. It's okay. The study is good, but unfortunately, we use the same brush to paint everybody, and we got scared of hemiarthroplasty. This study highlighted that the patients who are above 75 were the worst off. They had the maximum problem. So just because above 75 didn't do well doesn't mean that we should deny hemiarthroplasty to the appropriate patient. So that's important. What is very clear is that even he highlighted retroversion is very individual and not 20 degrees as Neer said. And we keep repeating ad nauseum that one has to be very careful to understand version. It took us 10 years to understand that version is different in every patient. And when we published our anatomical cadaver study, we were stunned that the maximum variation in the study on 65 cadavers was in version where there was variation from minus 18 to 55 degrees. So don't take that lightly. Boileau back then had highlighted that excessive retroversion was the commonest cause for failure of tuberosity. In an elective case, you have the luxury to measure the offset pre-op and post-op, and then you know that in this total shoulder replacement, you have balanced the soft tissues correctly. You have restored the original native balance that was there pre-operatively. We don't have that luxury because we don't have pre-op shoulder x-rays of these patients. So we don't know whether we have improvised or deteriorated these patients. Wrong version will create tension on the tuberosities, and with the first internal rotation movement, the GT will pop out. That is what you're seeing on this, that if the GT is positioned incorrect, if the version is positioned incorrectly, the very first time this patient is going to internal rotate, that GT will come off posteriorly because there'll be excessive tension on it. That's why it makes a lot of sense to position the version correctly. Then both the GT and LT will sit anatomically and will stay there. For stem orientation, there are several landmarks, but nothing is reliable as such. So from my point of view, I suggest that when you are lost at sea, and you're not sure what version to follow, look at the calcar. The calcar, although is round, you will see that at the medial end, there is a little spiking there. There's a sharp corner there. And that tells you the medial most zero uh, landing for your fin to point medially. In addition, the medial epicondyle, you must understand, points in the same direction of the head of humerus. So you can use that as an ancillary landmark and reconfirm what you think is the correct orientation. There are a lot of jigs with different companies. It makes it tedious. I have to make a very big incision to accommodate jigs, and they're imperfect because there are a lot of fiddly. All the surgeons that I know, no one uses a jig to estimate the height, and it's very tedious. So it's always the neglected part of the shoulder side which is lying there. We sat with evolutors and developed this. What I'm trying to point out here is to understand that when it's a trauma, you must use a trauma stem. There's absolutely no advantage in using a smooth stem which is uncemented in a trauma patient. That's a disaster. It's not a disaster, it's not an error, it's a colossal mistake. And so it's bound to fail. So what you're seeing here is a trauma stem with a GT in position. This is your trauma stem, which has HA coating, recession, hydroxyapatite coated, complete honeycomb appearance proximally. So that is what's going on. The one more point that I need to make here, and this is a new slide, is to understand that this is a trial reduction here. And what you're seeing here on the trial reduction is these are metal spacers. Most companies will give you plastic spacers. The reason I use metal spacers is when I fix the tuberosity, then I know exactly where the tuberosity is going to be. Because with the plastic spacer, it's very difficult to evaluate, have I positioned it anatomically or not? So this is an important feature of our trauma set, that all our spacers are metal spacers, so that intraoperatively, I get a correct feel, and I know that, no, this lesser tuberosity is not correctly placed, it's off, and it's not sitting right underneath the lesser tuberosity. Plus the offset, you can see here that there's a much bigger offset here posteriorly, and very small offset here anteriorly. So that means that I have factored in the medial and the posterior offset, because the head of humerus has a built-in posterior offset. That's very important. You all understand and know by now that I love the cerclage knot and the niche technique, and that has improved our cases, and we've not lost a tuberosity since we started using these two, knocking on wood heavily. Hopefully that's how it will. We've proven that the niche knot is far stronger than the surgical knot. Published that after doing studies on the machines. Now watch this. Through each tuberosity, which will be like a joystick where I can negotiate this. I don't use that for time. I don't like to pass sutures through the prosthesis. I like the bone to heal with bone. So I make two holes, one anteriorly. The anterior hole I use for the GT, and the lateral hole I use for the LT. So it's the other way around. And here, let me pause this video and show you that this is my traction suture. This is my traction suture, the green and the blue. The two whites are the circular sutures that are going superiorly and inferiorly all the way around in an orthogonal plane. So these are in the axial plane, the white sutures. And that is why it is very important to have colored sutures, so that you don't mess around and mix everything up. Because if you have 10 sets of green sutures in there, it's very easy to muddle up and tie the wrong sutures in the wrong part. I have a matter suture in here in the shaft, and another one here in the shaft. And let's see what we are going to do now. So always GT first. Is very important to use the traction suture to pull the GT, fix it in position, and then use the transosseous suture. This is a niche knot. The first simple knot followed by one loop through the one suture through the loop, and just keep tying it alternately one by one. So as you cinch it, it sinks down. The same thing you do for the lesser tuberosity here. So you have lesser tuberosity coming here, greater tuberosity coming here, and you finish off afterwards by doing these two circular sutures, which go around, simple round. So this has passed through the greater tuberosity or the rotator cuff, and then come around behind the prosthesis and enter through the lesser tuberosity here in the upper sector and lower sector. So in short, let me reiterate, we have brought GT to the shaft, we've brought LT to the shaft, we tied the GT first, and then in the recess filled in the LT. So they are fitted in. Because we use the knee smart, it's almost like a fracture reduction, hairline reduction. And then we didn't stop at that. What we've done is we've added two sutures, the circular sutures here, which go round in a 90-degree orthogonal plane. Once you're finished, and if there is no tension, then I would do a rotator interval closure for this with the remaining sutures that have been cut through. And that becomes a more comprehensive, judicious technique of fitting it in. This is one of my cases. I did an elegant job. I did for a very nasty 6-week-old proximal humerus fracture in a 62-year lady. I did a hemiarthroplasty, and perhaps I made a mistake there. My GT is healed, mind you. I have no problem. I have an elegant technique. The GT is healed. It's healed in exactly the right position. So if you see the apex of the head of humerus, and if you see the level of the GT, it's exactly 8 mm below, and it is consolidated beautifully in position. But at 62, this is a hypothyroid lady. Her rotator cuff was completely dysfunctional, intact but dysfunctional. And over 2 years, it has progressively migrated. She's miserable and she's not done well. And so I've had to revise this. And the revision is not easy because this is an uncemented evolutis trauma prosthesis. It sits there, trust me, doesn't easily come off. Canal, this is a mine, and you can see that bones are fragile. We've already got a circular suture in there. Now, when I revise that, removing of the stem is such a big challenge that I've used a longer stem. I've done a complete vertical osteotomy from top to bottom. This was well described by George et al., and we followed that. So you've actually done a bivalve, and you can see that entire vascular bivalve, but keeping all the muscle attachments intact so that you don't make that avascular. Fix everything, man. Get all the muscle attachments with the bivalve on the stem so that that doesn't become necrotic, and then do a hairline reduction and moves. But the point I'm trying to make here is that get it right the first time. Even experts can make mistakes. Good example of ideal fixation. Ensure you use a C-arm during surgery, and because it's important to understand what you've done there. If you've made a mistake, you can correct it in theater. Don't wait for the next day's X-ray to come and tell you that things have gone wrong. Finally, this is an interesting young patient. We've done a hemiarthroplasty for this late 4-part fracture, and everything seems to be doing well, but this was not healing. And it took us a long time to understand that although this looked in position, here there's fibrous union of the lesser tuberosity here, and that is not uncommon. There's a very nice paper by Vandenberg and Shahane from San Diego in general shoulder elbow surgery. They said the bone-to-bone union is the best, but non-union of lesser tuberosity and subscap dehiscence is not uncommon. Certainly avoid these kind of stems. This is ridiculous. It's probably made in some neighborhood garage and been sold off. Some of these companies are trying to market these stems. This is a monoblock stem of a very vague, dubious design. And you can see this is a disaster. This lady came to us 1 year later and was absolutely diabolical surgery. And so that's going to require a reverse shoulder replacement anyway. This is an interesting surgery from Gerber's unit 2013. Look at the primary hemiarthroplasty. They had 7 dislocations. 8 of 17 patients had issues. But revision surgery, they had 30% problems, and in lesser number of patients, and 11 of them had needed resurgery. So that means almost 28% resurgeries. 10 of those 11 surgeries involved exchange of prosthesis. So please take hemiarthroplasty seriously. It's not something that you can just pick up and do off the cuff. We have literature going both ways. If your tuberosity heals, your hemiarthroplasty do incredibly well. That's what Frankel's study shows us. But there is 11% incidence of failure in hemiarthroplasty in the Kontaki's study. But the rotations in a hemiarthroplasty are far superior than in a reverse shoulder in the trauma scenario. That is what one needs to understand. This was an interesting study by Forsada. It was a randomized study between reverse and hemi for fracture patients. And in this case, 56% had tuberosity healed. So almost 44% tubers did not heal. 30% were resolved, melted away. And 6 of the hemis of these 31 hemis had to undergo revision because of proximal migration. And then the UCL scores, again, reverses are higher, port flexions are higher, abduction higher. but the rotations were worse than hemiarthroplasty. Now that's a very good study. Again, it throws the scare that hemis don't do well, but you must understand Forsada's study was highlighted for patients more than 70 years. So don't panic. Don't use that same metric to apply to the younger patients. So as far as possible, I would conserve complicated patients, let them heal up and give them the ranges. But a good planning, which means that doing X-rays in two directions, getting pre-op CT scan mandatory for every complicated 3-part, 4-part fracture, soft tissue balancing and GT fixation, which means that using number 5 true bond, using the cerclage wire technique, using the niche technique, ensuring your tuberosities are sitting in home position, hairline reduction, and that after doing all that, they should heal up. Go very slow with rehab. We are very aggressive with rehab for our total shoulders and reverse shoulders, but when it comes to hemis, we don't have the testicles to allow them to start mobilizing, especially on the rotations. Patients above 75, I would be very sensible to do a reverse, because you want to do one operation that should be successful. However, the best results of a hemiarthroplasty cannot be matched by the best results of a reverse. But you must use a horses for courses policy to ensure what is right for that given patient, rather than use an agenda that I will do hemi for every patient as such. Thank you very much for your listening. We can take questions once you're ready.
Thank you, Ashish. Thank you, Ashish, for the elaborate talk on trauma hemiarthroplasty. Now, there are a few questions coming up. The first thing is about the cementation of trauma hemi. I think you have partly covered it. Yes, Ashish?
Yes.
Cementation.
So, yeah, most of the times I favor an uncemented process for all my hemis, but when it comes to trauma, I would cement only the distal stem. The proximal HA coat is left uncemented because we want our tuberosities to marry with that prosthesis. A tuberosity will mate to a good HA coat on the prosthesis. So cement only the distal part, 1/3, just to avoid rotations. And if you're using a rectangular stem, go and find out what stem you're using. Many companies have round steel polished stems. Those are dicey because they will not accept prosthesis and they will spin.
And if at all you use the uncemented stem, you have to be extremely careful about the height of the prosthesis. So it is not widely recommended.
That's right.
A question about how do you do color coding of the sutures if you don't have the color coding?
Right. Good, interesting point. You can always use methylene blue and dip your sutures in methylene blue so that you have them. And then if you want a third color, then you partly color them with methylene blue rather than the entire methylene blue. So you have some which are part methylene blue, some which are full methylene blue, and some remain green or white as such.
Raman, your tips?
No, I say you can use the different color of nerve holders on your artery forceps. You know, for your GT, you can hold all the 4 sutures in one artery forceps, which is differently colored with some colored rubber band, things like that. Use a nerve holder, nerve tape.
Any tips from you, Nandan? Suturing the tuberosities.
I said they can use electric bond and fiber wire together to suture bone and sutures.
The voice is breaking.
Keep your microphone away, Nandan. Keep your microphone away. Pull your microphone.
I can hear yours. Your voice is also breaking, so I think it's probably my line.
Hello?
Hello?
Okay, we'll move on to the next question. I think I have difficulty in hearing what Dr. Nandan Atla says. Anything done to the glenoid in hemi? I think the answer is very straightforward.
Never. Not for a 3-4 part fracture.
Not for a fracture, yes. I think I hope Raman and Nandan agree for that. So no need to do anything with the hemi.
Having said that, there is always medial erosion of the glenoid over time. And we are monitoring our hemiarthroplasties. After 10 years, they will have a reduction in the glenoid vault. They are completely asymptomatic. I'm suggesting that we need to revise them. Patients are just not willing. They're doing well, their movements are good. But I know we are measuring the glenoid vault will reduce progressively because you have a metal head against the glenoid.
Question: what is the position of arm while suturing GT and LT? What position you keep?
At least 45 degrees, depending on your balancing tension. Certainly never ever suture the tuberosities less than 30 degrees external rotation.
And second, for a successful hemiarthroplasty, you have to repair both the LT and GT. You cannot ignore. So
Absolutely.
that's very important for success. Then we have difference between trauma stem and other stem. I think you have covered it in your talk.
Yes.
Porous uncoating, fins, suture, tuberosity holes to encourage tuberosity healing. All these things I think have been covered.
Yeah, markings, horizontal markings, and the recession medially at the calcar area.
Horizontal markings in the prosthesis is a boon because you can put the trial in, you can check the mark,
Correct.
and you get the put the tuberosity, put the modular head, check everything, stability. If you want, you have an X-ray as well to make sure it's okay. Then you can put the
Yes.
real stem mark level, 1 or 2 or 3 level. So that is a good advantage with the prosthesis. Yes,
Yes.
Aman,
Absolutely.
any more questions? Are not covered. Do your Ashish, do your hemi get converted
Yes.
to reverse total shoulder? What is your experience? Your hemi.
Usually it is reverse. Usually it is reverse. I have couple of them that have converted to a total, but usually it's reverse.
Raman?
Yeah, it's usually reverse.
Yes. I think the failure, Nandan is audible or Nandan is here? Nandan, we get disconnected.
Hello.
So Dr. Adla is joining back in 2 minutes. His Wi-Fi has some issue.
Yeah.
Good morning, sir.
Stop immobilization.
I prefer not to immobilize. I can leave them down, but I avoid rotations. So the best movements to allow are pendulum, gently wiping the table and bracing the shoulder, elbow movements, but no rotations because that puts a lot of pressure on the tuberosities as such. And we continue that for 3 to 4 weeks. And at 4 weeks, we start them on active assisted with a stick, forward flexion, abduction. And at 6 weeks, then once it's healed everything, then that's when we start the exercises. But we have to prove that it has healed on an X-ray. If it has not, like one of those patients I showed you with a delayed union, sometimes I waited for 3 months for it to unite, and it does consolidate at 3 months.
Should treat like a displaced tuberosity fracture. Yes, Raman.
Absolutely.
Protocol for you?
Yeah, I mean the same. I mean, I'll just go at 3 weeks. I mean, until 3 weeks, I just wait in a sling with elbow and exercise, and maybe external rotation to passive, external rotation to 30 degrees neutral, and maybe passive elevation, passive hand under the elbow, 30 degrees. At 3 weeks, after checking the X-rays, I'll increase the range of the passive movements or assisted passive movements. And then at 6 weeks, again checking on the X-ray, I'll rather go for table slides and all stretches of the shoulder.
I think
but interestingly, there is the largest study of, I mean not hemis, but of course in the reverse.
Yes, that's
and they did 60% patients were immobilized and 40% were not, and no difference.
Yes. The reverse shoulder is different because we are not.
No, reverse shoulder with tuberosity reconstruction. Maybe reverse because of the tuberosity role in reverse has got a role to play in this, but certainly not for hemis.
Yeah, the deforming force of supraspinatus is not there in a reverse shoulder. And also the stem is quite medialized, so the leverum, the length is reduced. The blacks. The LT is also near. So the healing potential of GT in the reverse shoulder is much better.
Much better. Yeah.
In hemiarthroplasty, I think the message is protect it until
protect it. Yeah.
Because if that fails, your hemi will not work as you expected. Okay. So any method of pre-op templating in case of comminutor fracture as is in your practice? Pre-op templating, we do how?
We have templates. Evolute is provided us templates. We used to use them in our initial enthusiastic days when we had more hair on our head. Now, because with experience and with the fact that we can balance them out nicely, we tend to avoid them, but they are there. So you need the templates to measure the size of the stem and the size of the head and such things. Initially, good to use them initially to get used to it. So I still use them for complicated cases, especially revisions and such.
I think the question is probably implying to check whether you would like to do the opposite side X-ray and measure it, because the community is a bit lost.
Yes,
Maybe the concern for the
correct. Yeah, can be done for.
Yes. How to size the head of hip fracture?
So intraoperatively, the moment the head comes off, because it's fractured anyway, as I hand it over, my evaluative assistant, the first thing we'll do is measure it with a vernier caliper. I need the height of the head and I need the width of the head in the AP and medial lateral directions. And while I'm operating, he's telling me, so my calculations have started. That's the easiest and the most reliable thing to do. One need not spend time pre-operatively, but you can do that on your CT scan.
Yeah. And if in doubt, go for the smaller one. Raman,
the same. I mean, they've got the caliper, they've got the sheet with the holes in it where they keep their trials, and you can match the head with that. If the head is comminuted, I would rather go for the measurement between anterior, posterior, and the medial lateral, but I will keep the height low. The mistake is that when you keep the height high, then you overstuff the joint. So I'll keep the height low and go for a smaller one in all dimensions.
Okay, excellent. I think
the only time, Ram, I have found the templates very, very useful and critical to my success was when sometimes you not all companies have size 5 and size 6 stems. And if you don't have that on table, you're just going to explode that humerus completely.
Okay, we will move to, I think Nandan is going to come join. Can we ask Dr. Raman Agarwal to give his talk about reverse shoulder for fracture, nonsense tips and techniques?
Okay, Ram.
Can you share your presentation?
Can you see the screen now?
Yes, please. Yes. Put on the.
Yeah, Patka.
Yeah. Can you see it, Ram?
Yes, please. Very good.
Okay. See, most of the things for a reverse in a trauma situation has been very exclusively covered by Ashish, so my job is much easier just to show. So why do we need a reverse shoulder replacement in proximal humeral fractures? It's to restore the painless function of the shoulder in the elderly, preferably above 70 years of age, where osteosynthesis is likely to fail, and as Ashish said, severe comminution of the tuberosities, osteoporosis, avascularity, possibility of avascularity and head collapsing, and then your screws protruding into the joint, loss of head volume. Number two, where osteosynthesis has failed, where your internal fixation has failed, where your hemiarthroplasty has failed, and fractures with pre-existing arthritis. So these are the main 4 indications of reverse shoulder replacement in a trauma situation. And when not to do, especially in trauma, axillary nerve injury, and besides other contraindications to any joint replacement like infection and neurovascular status, but in trauma situation, these axillary nerve injury is very difficult to assess. So we need to be very particular about that axillary nerve injury. Concomitant acromial or scapular spine fracture, because when you implant your prosthesis and you lengthen the arm, so delta tension is going to disrupt those fractures. Concomitant glenoid fracture, because you need to implant your base plate. So you better be very careful what you are doing with your CT scans, and just don't decide on the X-rays, and Ashish emphasized it. You need to get the CT scan to rule out other concomitant injuries as well. So look at this case. It's a head split fracture in a 60-year-old man. So I found that greater tuberosity is a head split fracture. Some part of the head is going with a greater tuberosity. it looks good. Greater tuberosity looks good. And I don't find much of the osteoporosis. So as Ashish said, 55 to 65, I chose a hemi with good tuberosity reconstruction there. No reverse for this patient. But why do we need a primary reverse in fractures of the proximal humerus? Because it gives better results with less complications vis-a-vis osteosynthesis or hemiarthroplasty. And many very good shoulder centers have reported on this as recently as 2018, that there is a very high complication rate when you are revising a failed procedure to a reverse. For reverse shoulder arthroplasty versus hemiarthroplasty for acute proximal fractures. And we see many of the hemiarthroplasties had to undergo a revision to reverse. Secondly, the tuberosity resorption rate was 30% in hemiarthroplasty, where it was only 13.2% in a reverse shoulder replacement. And Ram, you gave the technical explanations for that of medialized head of the humerus, so less tension on the tuberosities. Now we come to the trauma situations where we have to do the reverse replacements more frequently now, and I think all of the faculty would agree. So this is Pascal Balu gave a good classification which involves the mechanics of the neglected trauma. So type A is where GT osteotomy is not needed, and it mainly involves the intracapsular problems like necrosis or a locked dislocation or a fracture dislocation. And type B, where GT osteotomy is needed, which is an extracapsular like surgical neck non-unions, which is type 3, and severe GT malunions and non-unions constitute the type 4. And this is a paper by Pascal Bolu, Jill Walsh, Bradley Edwards, big shoulder surgeons there. And they demonstrated that all the patients who had conversion to reverse in a type 4 fracture sequelae, they achieved very good results with more than 85% rating it as excellent or good. So my experience of reverse in trauma, there were 17 acute trauma cases and 8 revision or sequelae cases. In 17 trauma cases, I had 4 complications. 2 were instability. 1 was intra-op fracture of the glenoid. 1 transient brachial plexus neuralgia, which took around 6 weeks to recover. In revision case, of the, she's an 86 years old woman with acute 4-part fracture. And we thought that a reverse would serve it better to avoid any second surgery. So we did a reverse replacement for this lady and she is doing well. Now look at this patient. She had been living with arthritis, but the fracture of the surgical neck made it impossible for her to function at all. So in this situation, to deal with both the problems simultaneously of the fracture and the arthritis, we chose a reverse. And we were able to save the proximal head by not discarding the head and tuberosity segment because they're so essential for the rotations. So we were able to pass a guide wire through the original head into the medulla and then take a cut on the fractured head and implant the reverse. Now, reverse shoulder replacement for type 1 fracture sequelae, which is an avascular necrosis. Now, this patient had an injury in 2012. Initially, chest fixator was put. Chest removed 3 months after the primary surgery. Patient presented to me 4 years after the primary surgery with this picture. And we did all the inflammatory markers. Everything was done and found that patient doesn't seem to have any infection. And we went ahead and did a reverse shoulder replacement for this gentleman. But he developed infection after 3 weeks, and later on, his son tells me that yes, we did have a little bit of infection at that time, but that had cleared off in a couple of weeks with antibiotics. So just doing the routine markers in a previous surgery, especially the percutaneous ones, may not be a very good idea, and we need to have a very high index of suspicion of the patient developing infection later on. In this case, I removed the glenoid component. I could not remove the humeral component, which was a fully uncemented, fully coated stem, even after humerotomy. I left it at that and put a spacer there, and patient didn't come back to me. Probably his pain is relieved. Reverse shoulder replacement for type 2 fracture sequelae, injury 20 years ago. And the pain has become unbearable now. So we had to go for a reverse shoulder replacement because nothing else seemed to be okay, because the original morphology of the head is altered. See the offset, the head is so big. So when we did the reverse, now there was a problem. As you see, there is no bone there. Could not dislocate the whole head intraoperatively to see the full extent for making the cut. So developed instability, which we dealt with changing the liner again. Reverse shoulder replacement for type 3 fracture sequelae. Now this was a 55 years old female, 3 previous surgery with K-wire fixation and then removal, and has some bone loss. But this was the original X-ray. And probably I don't have any other view, because I think the original surgeon did not also have any other view and just went on and fixed the fracture with K-wires. That's how she presented to me. The head has even taken off the bone there medially. And it has been more than 18 months. The cuff is scarred. There's so much shortening of the cuff, contracture, and the reverse was the only option for us. Reverse shoulder replacement for type 4 fracture sequelae, GT not reconstructed. And all of us and all faculty would agree, probably this is the most common scenario where the surgeon missed the GT initially during fixation because they had been too focused on head and the shaft fragment. This gentleman presented to me 18 months after surgery, GT not fixed, patient is having pseudoparalysis, the screws are damaging the glenoid. So we know that just doing any other procedure is impossible because of the contracted GT, retracted GT, and the damage of the glenoid with the screws. So we did a reverse shoulder replacement. He was a short-statured guy. This gentleman developed axillary nerve palsy, which recovered in 3 weeks and is doing well now. But for 3 months, it gave me grief. Another example, 12 years old, operated non-union in 60 years old man. As you see, there is complete loss of metaphysis. Head is just a fibrotic scarred shell, and there's some wires, broken stainless steel wire. So I didn't have the advantage of that calcar or a metaphyseal deep there. So we did a contralateral humerus length measurement. And then this was his glenoid during a reversal. All glenoid was totally fibrotic and scarred. So we did a long stem reverse shoulder replacement because there was no metaphysis. Although in hindsight, I think I could have done with a normal stem here as well. But at that time, I chose a long stem by evolutus. RSR in failed hemiarthroplasty. Now, I don't have the pre-op, but this was done somewhere else. Look what the surgeon did. That's the Gothic arch, natural Gothic arch. It has been implanted at least 2 centimeters high. The head is at least 2 centimeters high. Obviously, you don't see any tuberosities there. And it's not only high, it's more than 60% of the head is anterior. So it's practically an anterior superior escape. Did a humerotomy at the surgery, able to do a good replacement, reverse shoulder replacement, and there were no tuberosities, of course. Unfortunately, the patient fell 3 months after this surgery, developed a periprosthetic fracture, and then we had to put a plate. So at the moment, the function is only 90 degrees elevation, but no pain, and she's okay with that. Another example, 75 years old woman with bilateral proximal humeral fracture with pre-existing bilateral shoulder pain. So we thought this is perhaps good to go for a bilateral reverse shoulder replacement in this. Left side went reasonably well. Part of the GT is flying, but part of the GT is there. But look at the right side. During surgery, had a glenoid fracture because the assistant was standing on the opposite side with his Colbell glenoid retractor. He couldn't see the glenoid, and he just pressed it hard, and glenoid was in my hand. So had to bail out with reconstructing the glenoid with the head of the humerus and do a hemi. Now that is her function, and you can rightly judge at 3 months, Left has a reverse shoulder, right has a hammy. That was the internal rotation with the reverse shoulder. So beware. In a fracture situation, glenoid is not arthritic and hard and sclerotic. It's osteoporotic and weak. So there are complications, and all the series report the complication to the tune of 20 to 21%. But look, of all the indications for reverse shoulder replacement, this is the acute fracture and rheumatoid arthritis. Ashish mentioned rheumatoid arthritis. These are the two subgroups in reverse shoulder replacement where the complication rate is very high. And there are risks of intra-op complications like blood transfusion, pneumonia, myocardial infarction. This is the odds ratio, acute mental change, as they are elderly. Now, this is a gentleman who did a 3-part fracture in 70 years old patient. And we did a reverse shoulder replacement with tuberosity reconstruction. And you see a little bit of the tuberosity is resolved, but major still seems to be in place. So that's the function of the left side reverse shoulder replacement, but with healed tuberosity. And that's his internal rotation. So are there any concerns? Now, this is one of the largest studies published in 2016, and there were 11 centers in France. 9 did the reverse shoulder replacements, and one of the authors is Silviox, is a highly respected name, and they report the overall complication rate, overall failure rate of 25%. But they do have 6 complications in 72 patients, which were followed up out of 113. And rest of the patients had constant score, weighted constant score below 70%. The only recommendation of this study was that superolateral approach gave better outcomes. Constant score was 10 points better. But then most of the series, which had gone through in this paper and the previous series, the surgeons have been using superolateral approach quite frequently, and they are quite tuned to that. So what works is deltopectoral approach. That specific indications would include fracture dislocation injury, and if the fracture line is extending into the metaphysis, don't fall into the trap of doing a superior approach because we might be in trouble there. And the advantages are anterior deltoid is spared and upper edge of pectoral metaphysis tendon can be referenced, however, may not be needed. So what can we do to get it right? And now this is not a dictum, but this is, I think most of the surgeons would agree on most of the points here. This is what I do in my practice. Glenoid is osteoporotic, so be gentle. 0 to 10 degrees inferior tilt, depending on the implant. Get the retroversion to less than 10 degrees in pre-existing arthritis. Base plate flush with the inferior margin, so when we implant the glenosphere on top of the base plate, there is an inferior overhang of 3 to 4 millimeters because of the inbuilt design anyway. 36 millimeter glenospheres usually work very well. Superior screw into the coracoid base and inferior screw perpendicular to the base plate so that it's not parallel to the lateral pillar of the scapula, but rather going at an angle, but perpendicular to the base plate so that if in case notching happens, it will not touch the screw. So what can we do to get it right on the humeral side? Correct height. Of course, Ashish has gone in detail, but I usually base my estimate of height on calcar. I do find the medial spike of the calcar, and I base the medial part of my trial on that calcar, and then I build, and then I use the C-arm to see whether Gothic arch has been restored or not. Then I bring the tuberosities around and see there is no tension in the tuberosities, and it is sitting nicely 7 to 8 millimeters below the head, then I accept that position. Correct version, I usually use 20 degrees while doing a reverse. The more retro version will put a more stretch on the greater tuberosity. So I usually restrict myself to 20 degrees. And then again, I use the calcar as from the lateral to the medial side, from the quadrangular shape, and it goes on to become triangular where the posterior medial cortices meet. on the calcar area, and that's the medial side. Coated trauma stem, Ashish has shown beautifully. The evolutive stem has got proximal coating, distal smooth finish where you can cement. Remove the cement from the canal much in advance. And Mark Frankel would actually use the bone graft packed on top of the cement and then insert it instead of putting the graft later on. Meticulous osteosuture of the tuberosities, and that video which Ashish showed is a fantastic technique of looped threads and getting the loops through the loops and tying a niche knot. That's very good. Finally, check the forward elevation, look for impingement in rotations and tension of tissues and pistoning for stability. Now, these are all very essential steps to achieve a good outcome. Despite that, instability forms the most common complication and the reason for revision in a reverse. And if you are in doubt whether we can actually achieve that, and Ashish did mention that, leave it as such. Now, this is a paper and it's got very big names, including Tokish and Hawkins there, who say that they followed 19 non-operative and 20 RSA patients for 2 years. No difference even in the patient reported outcome. So if in doubt, if we can't improve the nature or the outcome, we should stay put and not do it. So my take-home messages would be, get it right. The most important message is, if we are touching the proximal humerus, we need to make sure that our fixation or our hemi works well. Tuberosity reconstruction in reverse shoulder replacement improves ER, so don't disregard the tuberosities, don't throw the head away. Revision situations have very high complication rates, so try not to get into that situation. Be meticulous with positioning of the implants. Be meticulous with positioning of the implants, as instability remains the biggest concern. Be very wary of excessive lengthening, especially in Indian women because of nerve injuries. So limit your lengthening in case you think that you are having a very short stature individual. And if you have an eccentric glenosphere, choose your base plate in the center and not in the lower half. Thank you.
Thank you, Raman. It's very detailed talk. Now, Smriti, can you put the grid view of the panelists? So we'll just take some questions, Ashish.
Yes.
Okay. Now, Raman, I think you have covered the questions being asked in the chat as well.
I don't know.
Okay, no, you have covered in your talk, but they were asking questions, which is replying to it. The question is, what is your favorable approach for reverse shoulder for trauma?
The surgical approach.
Can you remove your screen?
Oh, just a minute.
Screen sharing.
Yeah.
And then put the, Put the grid.
So I am a dedicated deltopectoral man. I do not use the superior lateral approach because of two reasons. I'm really very scared of damaging the axillary nerve.
Yes.
I'm really very scared of detaching the anterior deltoid, which is the workhorse of reverse shoulder. So because of these two concerns, just because the instability rate is higher in deltopectoral, I have not changed over to the superior approach for my reverse. For whatever, I still stick to the deltopectoral approach. Number two, I personally believe you don't get better with one surgery. You do 100 surgeries, then only you get better. All the complications which happened to me with my initial 20 reverse, 25 reverse shoulder replacements, and I'm getting wiser. So I will not change my approach because I was trained on deltopectoral and I have done deltopectoral exclusive for the last 20 years. So I'm going to stick with deltopectoral. But yes, you have to make your own decisions in this regard.
Yes, Ashish? Nandan is back as well.
I think.
Yeah, I'm back.
Yeah. Raman made a very important point that your learning curve improves with time. You cannot expect to do your best case first. About the approach, the interesting thing was I was trained on deltoid split approach, and I thought that was the answer to global warming. So my first 100 cases were deltoid split, and my colleagues and my friends, surgeon friends, still continue to use the deltoid split approach. Then when I was arguing with another senior surgeon who was a dedicated deltopectoral chap, I tried to explain to him that the complication rate of deltopectoral is always twice that of the deltoid split, like the study that Raman showed. And this is where we need to read between the lines. And that surgeon told me that, Ashish, all complicated cases are done by deltopectoral.
Yes, including revision.
In which case, including revision, including trauma, in which case the complication rate of the deltopectoral approach is always going to be higher than the deltoid split.
Yep.
So you read between the lines. So for trauma, I never use deltoid split, never ever, because you need a wide extensile field. You need to get all the tuberosities together, and you want an approach that you're very commonly used to. Deltoid split remains my most favorite approach. I save 30-40 minutes of my surgery time. I use it for very simple, straightforward, tough tear arthropathies. I still do it.
Yes, I think you have to be aware of limitation and indication of these two approaches. For
Correct.
a simple, straightforward cuff tear arthropathy with no need to do any extensive soft tissue release or glenoid work. And second indication is a 4-4 comminuted fracture with no dislocation, with no extension of into the fracture down the shaft. Then you can use the superolateral.
Yes.
For all the other indication, if you're doubtful, better go for deltopectoral as it is extendable.
Yes.
The dislocation rate is as you correctly explained. Okay, that's fine. There are more questions coming up. Okay, how do you avoid lengthening with reverse, Raman?
So this is something. I mean, this is very implant specific. Usually, I mean, the standard teaching and the experience is that you base your base plate metaglean at the inferior edge of the glenoid, where the long head of triceps, and how to ensure that you expose the inferior edge of glenoid. Unless you don't see the long head of triceps, you have not done it. So I go base by metaglean or the base plate at the inferior edge of the glenoid, and then I implant it. But if I have got an implant where I can slide the glenosphere slightly inferiorly onto the base plate to achieve that inferior hang to avoid notching, then I would implant the base plate slightly superior, maybe in the center of the glenoid, and use the modularity of the glenosphere over the base plate. In case I find that the patient is short stature, and this has happened with me, and I think this is why this is one of the reasons why the Japan never approved the reverse shoulder replacement until 3 years ago, because of the excessive rate of nerve injuries because of the short stature there. So in that case, you have to be very, very choosy. I mean, of course, you will use a smaller glenosphere, a 36 glenosphere, and you may implant your glenosphere slightly superiorly, even if it doesn't give you the modularity, because there is a 4 millimeter glenosphere. When it sits on the metaglean, the inferior side is going to be 4 millimeter. You are still going to be okay. So if you find a very short patient and you don't have a modularity glenosphere, still go 2-3 millimeter higher and implant the base plate there, you will still be okay. But at the end of the day, your construct, including glenosphere, should be overhanging by at least 2-3 millimeter. That's very important.
It's the question about an accidentally fracturing the proximal humerus while reaming. What is your choice of fixation?
Oh, it is already fractured in a trauma situation. There is no question of that.
No, is it split of the proximal humerus while reaming?
Splitting of the humerus.
You want to do a primary or something.
Oh, okay. So this does happen, especially with a non-cemented stem. So in humerus, the very interesting point is of reaming, as we are used to do a reaming nail. We talk of cortical contact. In humerus, you don't talk of cortical contact. In humerus, you just talk of rotational stability. You have to stop very early. You have to stop very early with your reamers. As soon as you find that cortical engagement sign on the reamer, stop. Probably that's the point. And then you go with your trial broach and you go one size down, because especially in evolutis, the coating is 0.75 millimeter on one side. When you take two sides, it's going to be 1.5 millimeter. So you stop short or broach less. I always use one size less than the implant in broaching, and then I impact the implant.
And this is the...
If you choose the same stem, there will be a chance that you will splinter the humerus. And then if you do it, you have to recognize it. You don't need to panic. You have to have a plate in the OT on the shelf, open up if the fracture extends quite down. But if it's just a groove on one side, leave it in a sling, it will heal.
I think perioperative, if you encounter when you're trying to do uncemented, there's a small split starting. It is easier handy to put a sucklage wire inside and then put the real cemented stem in. Okay, I think the next few questions will be covered by Dr. Nandan in his talk. I'll just invite Dr. Nandan to talk about total shoulder replacement, planning and pitfalls. Thank you, Nandan.
Thanks, Ram.
Can you share your screen?
Is it coming? Is it projecting out?
Yes, yes, yes. Just put it on show.
Yeah. Okay. Now, you've been hearing about how to treat fractures, mostly by hemis and reverse shoulder replacement. This talk is basically on total shoulder replacement. I'm going to mostly cover only the preoperative evaluation and the technical pitfalls. That means I'll go through the surgical technique in detail. I'm not going to present a lot of outcomes, and I'm not going to talk about short stems in this talk, because that's a different talk altogether. Okay, and now when do we do a total shoulder replacement? Unlike in fracture situation, we do it in osteoarthritic glenohumeral joint with a painful and stiff shoulder. So what do you need to do? You need to assess the clinically assess the range of motion to find out the stiffness and the source of pain and the cuff function. The cuff function is the most important deciding factor when we decide on a total shoulder replacement or a reverse shoulder replacement. Now, with the reduced shoulder function, all of my patients actually get an Oxford shoulder score before surgery. And this is important because this will help evaluate your outcomes post-operatively too. Now, clinical examination wise, it is very important to know where the pain is coming from and the exact type of pain, because if you don't determine that and you just go by the x-ray, then you might end up doing the wrong surgery on the wrong patient. Occupation is important. So if you have a heavy laborer, you do not do a total shoulder replacement, or sometimes even a reverse shoulder replacement. Always ask about recreational activities and look at comorbidities, obviously. I think the most important deciding factor when you want to go in for a total shoulder replacement or a reverse shoulder replacement is age. Now, this is where I got a bit stuck initially, because the way the Indian patients behave at 60 is different to the way the Caucasians behave at 60. So this is where the decision making comes into play. So if you see a patient and you feel that there is unlike potential that he is going to rehab or she is going to rehab her cuff well after surgery, then you might be better off going in for reverse shoulder replacement. But if you feel that they're going to rehab well, they're young patients and they have a concentric glenoid, then you should think of a total shoulder replacement. Unfortunately, after the advent of reverse shoulder replacement, more and more people are actually going in towards reverse shoulder than total shoulder replacement, even if the cuff is intact. But we just have to wait for the time and see which is the best approach. So far, the outcomes of a total shoulder replacement seem to be better than a reverse shoulder replacement in primary osteoarthritis of the shoulder. So examining the site of pain is important to know where the pain is originating from. Always check the rotator cuff function. And now, because there is stiffness in the shoulder, you might question the assessment of the rotator cuff. But simple resisted external rotation, like is shown, if you do this test, then you can find out if the infraspinatus and supraspinatus is functioning well. And a bear huggers test, which does not require a lot of movement at the shoulder joint, you can do this for the subscapularis test. And for the deltoid, always check the deltoid if you're planning to do a reverse shoulder replacement, because without a deltoid function, the reverse is not going to function properly. Neurovascular status, obviously you have to do that, but this is one thing I would suggest do it more thoroughly, because do a Sperling's test, look for neck movement, especially if the patient is rheumatoid. And if you have a rheumatoid patient, the chance of having an unstable cervical spine is there. And if you put the patient into a beach chair position and positions which are in what we use in shoulder surgery, it can damage the cervical cord as well. Okay, and patient's fitness for surgery should be assessed like any other surgery. Now, in examination, the clinical examination, you should always look for both active and passive range of motion, mostly looking for any soft tissue tightness, and if there is any mechanical block because of the osteophytes, and if there is any weakness in the rotator cuff and the deltoid. And I think a poor effort due to a weak cuff can be a problem if you're planning for a total shoulder replacement. Imaging wise, very important to get an X-ray, a good X-ray, a true AP view where you can see the glenoid as one line, and an axillary or a strip view to assess the glenohumeral space. A CT scan is now become more of a routine thing for me for total shoulders, mainly for planning purposes, because I'll touch upon this in the next slide. And MRI, if you take MRIs for glenohumeral arthritis, only less than 5% of them are associated with rotator cuff tears. So clinical examination, I think, is more important. And also assessing a fatty degeneration on MRI scan might help assess the amount of rotator cuff function you will have post surgery. As far as the radiograph is concerned, things to look for are these: the medialization, that means there is erosion of the glenoid here, and the whole of the humerus is medialized. So look for the amount of medialization by looking at the lateral end of the acromion and looking at how much the glenoid is worn in relationship to the base of the coracoid. Now, looking at the other aspects are the superior migration, which will tell you how much the rotator cuff is dysfunctional. So reduction in space in the suprahumeral area will help you assess that. And also the loss of Gothic arch, like so, will tell you if there is a functioning rotator cuff or not. And if you have a superior migration or an inclination of that, you should always go in for a reverse shoulder replacement and not a total shoulder replacement, as the rotator cuff is not functional. The CT scan is important because you'll get a three-dimensional and a cross-sectional imaging of the glenohumeral joint, and this will tell us if there is any posterior wear, because this is very common. About 40% of the glenohumeral arthritic patients can have a posteriorly placed humeral head and a degree of wear on the posterior aspect. So if there is significant wear, then you should consider more towards a reverse shoulder replacement, because the total shoulder replacements cannot be screwed on or fixed with any bone graft under them to correct the version. But in that situation, you may have to over-ream and do it, which will reduce the amount of bone you will have on the glenoid. So will not have a good hold for the glenoid component. Humeral side assessment, look for head thickness, offset, canal diameter to see which stem goes in, and the thickness of the humeral cortices. And this is important to assess to avoid splitting of the humerus when you are actually putting in an uncemented humeral stem. And looking at the assessment, this is the planning I normally do for most of my shoulders, where we look at both the axial cuts and this cut, because this will tell us the amount of erosion medially. This will help determine how our component is going to go on to it. And if you are doing a reverse shoulder replacement, there is a possibility that you will face the glenoid more superiorly, glenosphere more superiorly than inferiorly if you don't judge this tilt, that is the superior inferior tilt of the glenoid erosion. And 3D imaging is useful. You can even get a 3D model for helping you with your intraoperative planning. So if you have an erosion like this, I prefer to go for a reverse shoulder replacement, not a total shoulder replacement. Patient selection for a total shoulder, if you want a winner, is go for a glenohumeral joint osteoarthritis, relatively fit elderly patient. That means who is somewhere below 70 years of age and has a good cuff endurance, not just the function, but the endurance and the possibility of them rehabbing properly. The biggest I've learned from my mistakes, I've initially done a few total shoulders on patients who are 70 thinking that they're very fit. But in one patient, there was a crack on the greater tuberosity and the cuff didn't function well and she never had a good outcome. The other patient did not rehab very well afterwards, so the cuff did not fire. So she always had some degree of discomfort in the shoulder. So now I'm very selective in who I do a total shoulder. I'm thinking total shoulder might go the way the hemiarthroplasty did in the shoulders, but we should wait and see. Now, anesthesia point of view, very important pitfalls to look for. Use a reinforced tube, fix the tube correctly because most of the head is covered when you're doing your shoulder surgery. So be careful and always use preemptive analgesia like this, the patches, which will help in pain control. We always give interscalene block for pain control too. Position them either supine or slightly propped up position, but you should be able to support the pelvis so that they don't fall off the table. One, secondly, you have the arm free and the arm should be able to go 90 degrees perpendicular to the floor because this will help you when you're putting in your humeral component and to get your version right. So having the arm free is important and secure the head too. Approach wise, just a short video, and I normally do a delta pectoral approach because I've been more familiar with it. I've done superior approach for total shoulders also in my training, but I preferred this approach because it's more of a universal approach that Raman just mentioned. So we raise the flap medially and identify the fat between the deltoid and the pec major to get into the groove. Then do a finger sweep in the subdeltoid area so that you can retract the deltoid laterally and now expose the humeral head and the proximal humerus. Identify the long head of biceps, isolate that, do a tenotomy, and I tenode the distal end of the long head of biceps onto the pec major and get into the interval. Then identify the subscapularis. Once you identify the subscapularis, the first step to do is to put a suture onto the subscapularis tendon. Very important to secure the tendon. That's the tenotomy done. That's the subscapularis tendon. Put a suture to a stay suture on it. And you can either do an osteotomy or that's an osteotomy I'm just showing, but you can do an osteotomy or a tenotomy. The results are equal, but with an osteotomy, you can actually look at the healing of this post-operatively if you have any doubt, but with a tenotomy, you don't have that luxury. That's one of the advantages. And the other advantage is when you do an osteotomy, your access to the glenoid becomes easier because many a times when you ream the glenoid, you will tend to abrade the lesser tuberosity. And the humeral site preparation. So you take out the osteophytes, always take out the osteophytes so that you know the true articular line of the humeral head. So that is the usually 135 degrees and that is equivalent to the stem angles. So you make a notch on the top of the head and go in with a straight reamer and use a jig to cut and make sure that the retroversion rod is in line with the forearm. It's very important that many a times these jigs can be very confusing. Sometimes the cuts you get after using a jig can either go onto the rotator cuff and posteriorly can damage the cuff. So you should be very careful when you're cutting. And that's the medial calcar, and that gives me the version, the native version of the patient. So you put the component in facing the native version. And the 3 points you look for, that is the medial calcar, the medial epicondyle, and also keeping the arm in neutral and see if the humerus is facing towards the glenoid. So if you look at this is the other technique I use where I basically use the marker, the articular line, and we use a saw to cut the articular surface. This is done freehand, and I've noticed that this also gives you very accurate results, but do this only after you've had a lot of experience with the shoulder replacements. As far as the glenoid exposure is concerned, once the glenoid is exposed and the humerus is retracted backwards, you see there are not a lot of retractors. I don't tend to use more than 2 retractors when you're doing a glenoid because more retractors, the crowd is there is crowding at the space and you'll not be able to see the glenoid very well. So you mark the glenoid, get the center of it, put a wire through the center with a jig and make sure there are only 2 peg holes in the evolutus system. That inferior peg many a times can come overhang downwards, and it can be a problem in ladies in Indian situation. So be careful to place that slightly superiorly than inferiorly, whereas in a reverse shoulder you have to place it more inferiorly than superiorly. So this is the concentric reaming you do with for a total shoulder. That's a trial, making sure that the size is the same. Then you make the peg holes. The peg holes, the beauty of the system is the peg holes are same for size 1 and for the size 3. So once you have dried the whole thing, then trial in the size, make sure that it's completely bottomed out and it's not rocking, and you dry it, clean it. The important tip I would give here is not to ream too much, just get onto the subchondral bone and make sure that the glenoid component fits in correctly without any bit of rocking, because the rocking is what gives you bad results later on. And I feel the thumb is an excellent way of pressurizing the glenoid onto it. Some points I would like to point out, some tips are that if you look at this retractor, it's not actually retracting. This is actually guide for your anterior edge of the glenoid. It will go onto the neck of the glenoid, and this guide wire can point to the tip of this. So this will go into the triangular bit of bone on the scapula. So you get the version and your angle right. And reaming should be concentric, so the reamer is not going outside and only go just subchondral. You don't have to see the bleeding bone. And the sizing is very important to get all the edges of the glenoid covered, and it should not be overhanging, it should not be underhanging. So getting these edges correctly on the glenoid is important. And cementing, always cement only the holes, do not put cement at the back of the poly at all, so that you don't get that thin film of cement which could crack and cause loosening of the glenoid component later on. So the final part, when you do this is a drill holes like Ashish had mentioned for suturing of the subscapularis. I didn't use the knee knot at that point of time, but it's a very good, knee is a very good way of repairing this rotator cuff back on. So put these sutures on before you put in the humeral component in. Again, the native version of the patient is what you go for, and the surface of the humeral component should be matching with the cut. And when you place in the humeral head component, you should not have any overhanging in the front, superiorly and posteriorly. And once you have put in the trial component, you can check for the tissue tensioning. If that rotator cuff comes back into place easily, that means your cuts are right and your tension is right. Once you impacted the real implant in, it is best to check that this does not come out of its groove. So give it a light tug like that to make sure that it is impacted in well. And then check for the tensioning. If you push the head backwards, it should pop back in by 50%. And you see the conjoint tendon is also relaxed. And now repair the subscapularis back on. It's very important to take this part of the surgery very, very meticulously done. So otherwise, if there is a failure of the subscapularis, the shoulder replacement is not going to work, especially in a total shoulder replacement. Rehab, I put them in a sling for 3 weeks and start passive motion after that. And then active assisted after about 4 weeks, and then start strengthening at about 6 weeks. So if you have a concentric osteoarthritic patient and if you do a total shoulder replacement, you can expect very good results where you cannot make out which side was operated on, and the patient is very happy. But if the patient selection is wrong, then you will have very bad outcomes. So please be very careful when you're going in for a total shoulder replacement. And not all patients require a reverse shoulder replacement like is being the trend right now. Thank you.
Thank you, Nandan. We'll take one or two questions, then I finally summarize with my complication talk. How do you use the jig to cut the humeral head?
The jig, I've shown the jig to cut the humeral head.
Any precautions to avoid damage to the rotator cuff while you're doing the primary?
That's what you have to. You have to have a marker on the supraspinatus attachment, and I put a retractor at the back to see where the infraspinatus attachment is there, and you have to keep those two as your protection for the rotator cuff, and make sure that the cut never exceeds over that.
Yeah, I think as such the cutting or osteotomy of that is not very much important in reverse shoulder, and it doesn't is not important in trauma cases. Okay, it's applicable only to the primary situation.
So Ram, can I ask one question?
Yes, please. Yes, Ram.
So Dandan.
Yeah.
So I fully agree with what your apprehensions of doing a total shoulder in an elderly Indian woman.
Yes.
I just want to know your criteria. Say you got a 70 years old woman,
yeah,
and you are kind of, you find that it's a primary osteoarthritis, no sign of cuff disease. Clinically, you find the cuff is painful, but still good. Okay, you get an MRI. And then you say, okay, should I do a total shoulder? She is 70. And you are kind of in a dilemma. What is that dilemma?
The dilemma I have is when I talk to the patient, I want to see how active she is.
What is that?
And how fit she is physiologically. This is something you get.
These criteria are not defined, and that is where we get stuck.
Correct.
So I ask the patient,
mm-hmm.
Are you happy to do a 6 months difficult rehab if I do a total shoulder?
Yeah.
And I tell them, look, this is going to cost you whatever, X amount, and there is another operation which is going to cost you maybe 1.5 times more. That's the reverse. And you don't need that rigorous rehab in that. Which one would you prefer? And invariably they will come back, oh yes, we will do the rehab.
Yes.
2, 3, 4 months down the line, they are stiff and they're not progressing, and then they're blaming you. I mean, Ashish is smiling, Ram is smiling. Everybody faces this. And I asked this Ashish this question in one of the previous webinars. One of my patients, mother of a doctor, all doctors in the family, and looked very good to me that she will do the rehab. I did a total shoulder. She's achieved the passive range of movement, no axillary nerve palsy, but she has not recruited her deltoid.
Correct.
Yeah, bizarre situations, but yes, they do happen. So I just wanted to take the view of all the faculties there.
So I'll give you my view. The way I look at it is one, I look at the duration of her symptoms. One, if the duration is too long, that means they've had it for a long time and it's an erosive type of arthritis and there is medialization. And if I feel that they have not moved the joint and on examination, the movement is not so much and it's completely stiff, then I feel that this patient will have a proximal humeral osteopenia, will have a rotator cuff dysfunction. And so the chance of the glenoid, the greater tuberosity probably having a fracture or the cuff recruiting will be lesser. So in these patients, I would have a low threshold to going in for a reverse rather than a total shoulder repair.
Ashish?
Yes, it's always a challenge. I still have a handful of patients who are like the patient that Raman described. I can't deny that. But over the years, I've become wise and I know how to pick up the patients. So there are objective criteria and there are the other soft criteria, which are intuitive criteria. Like Nandan said, I look at this patient, I don't think he's going to do well. But the ones, apart from the ones that the B2 glenoids and the severe medial erosions, not to be done, elderly, not to be done. The ones where there's a lot of fatty infiltration. And that's why I always do an MRI on every total shoulder case. The ones who are hypothyroid, the ones who are unlikely to come back for rehab. They say you do the operation and I will go and I will manage for myself. There's no chance. There's no chance. I have a few patients from Africa, a few patients from Dubai who are like that, and I will not risk it because a total shoulder not only requires perfect surgery, accurate precision surgery, it requires precision rehab. which I'm comfortable. I'll tell the patient, you operate under me, you do rehab under me, we will do it. So these are things, criteria that you have to be very careful about.
I think that's the last one is important as well. The main, as you said, objective, subjective, but the subjective rehab potential is the key. If the patient with the anatomical shoulder replacement, it's not only the muscle, the quality, fat infiltration, as well as chronicity, plus rehab potential for the particular patient and the caretakers. If it is not likely to be in your subjective assessment, I have a very low threshold of choosing reverse shoulder, because the reverse shoulder, you don't need to worry about the rehab. You can let them go free, move. No need to have very methodological follow-up as like a primary arthroplasty, anatomy.
Yeah.
Okay, I'll just move to the last talk. That's the complications. Can you hear my? Can you see my PowerPoint?
Yes, very clear.
See, the whatever we say or do, the proportion of reverse shoulder to all the other types of shoulder replacement is increasing. This is the global trend in UK as well as Swedish registry, is global phenomena. This is the complication list. It is slightly different in terms of reverse shoulder compared to anatomic. In the reverse shoulder, its instability is the main problem. Periprosthetic fracture, infection, and component loosening. This is the slightly bit different order. But it is not like anyone is immune to the complication. This is the example of a picture of a patient with the 7 complication shown from the shoulder group Pascal Boileau. The patient had dislocation, revision, infection, 2-stage revision, and again dislocation, had 7 operations. So nobody is immune. So this is the complication that is being listed is a dislocation up to 20%, scapular notching, varying rate, nerve injury 3%, infection up to 5%, glenoid humerus acromion fracture, and the base plate component loosening. So dislocation is the key complication. Happened more in the past because he had to remember reverse shoulder was done, as Ashish highlighted, was done for a salvage indication in the past. But now we are doing more for a primary indication in arthritis or arthroplasty or arthropathy. So the complications obviously had been higher in the past. The reasons for this is poor deltoid tensioning, whether you put a superior base plate tilt or medialize the glenoid too much, or a weak deltoid in a situation of injury, rupture, or acromion fracture or axillary nerve injury that can cause dislocation. Mechanical impingement with bone or soft tissue or implant related. And the other key thing is the glenosphere size. The bigger, the stable the shoulder is still working. So we show an example of a dislocated reverse shoulder in a rheumatoid arthritis patient. She had a fall and dislocated the shoulder, a close deduction. Again, she re-dislocated. So that is the CT scan shows the good incorporation of both glenosphere as well as the proximal humerus. So here she was revised with the larger glenosphere. The glenosphere was taken, revised to the larger size. This is her at 2-year postoperative doing well. You have to remember the rheumatoid arthritis patient are notorious for to have more complication than any other subgroup. This is another patient, severe rheumatoid arthritic patient, operated 3 months, and she went elsewhere, had an injury and dislocated the shoulder, unstable. So she was revised. She already had the biggest hemisphere put on. So we have to increase the liner thickness. So this is a surgery showing the constrained liner. We rarely use a constrained liner because the constrained liner restricts the range of movement of the shoulder but provides stability. So to avoid dislocation, we had to get optimum deltoid tension. Still, this is a subjective phenomenon in the reverse shoulder arthroplasty. Definitively avoid superior base plate tilt, which is not a good sign, good thing to do. Avoid too much medialization of glenoid. Avoid mechanical impingement. You do a trial and then correct it. Subscapularis preservation or repair might increase the stability. And they also put a final check by putting the arm in at-risk position to check, because this is the last chance for you to adjust the tension before you close up the wound. So technically speaking, the dislocation could be due to either humeral shortening or humeral medialization. So if it's a humeral, this could be sorted out by 2 mechanisms. One is enlarging the glenosphere or thicker PE. That is a minimum step to do. And if it is major, we have to reconstruct the humeral length. Scapular notching is reported up to 60% of different grades. They tend to stabilize after 1 year. There is controversy as to the clinical significance. but definitively higher grade notching should be avoided because they are associated with low constant score outcome. So this is an example showing 1 year notching of the scapula, but asymptomatic. So there are a lot of things you could do to reduce the notching, do a very good inferior soft tissue release, restore the humeral length, inferior placement of the base plate, which was described when we started to do reverse shoulder in the past. Inferior glenosphere tilt is possible, but the most important thing is to have a large head, eccentric hemisphere, or a lateralized sphere. This will automatically avoid notching. Nerve injuries, I think, has been covered. Any reverse shoulder will lengthen the shoulder. So this is the distance now after reverse shoulder. There is some stretching of the nerves, but they do recover. Very rarely you have a permanent palsy. Hematoma and infection reported up to 5% because there is a lot of dead space after doing reverse shoulder. It is not like anatomical shoulder. So you have to reduce the dead space by doing tuberosity subscap repair. In my practice, I leave a suction drain for 24 to 48 hours. And the slightest suspicion the patient is having a temperature, I take them to theater to surgically evacuate the hematoma if required. Intraoperative fracture has been covered already. If there is a split, a simple thing is to put a subclotch wire and cement the processes in, or even use uncemented processes at times. Periprosthetic fracture can happen. This is a successfully treated reverse shoulder arthroplasty for four-part paternal fracture dislocation. The patient went home in 6 months' time. She fell down and came back with a periprosthetic fracture. A periprosthetic fracture of anatomical shoulder can be mostly treated with conservative measures. But in a reverse shoulder, the torque is much higher, especially if the fracture is below the stem. So I had to plate her with a locking plate and subclotch wire at the proximal section. The fracture is healed. But this is something which, if it happens, you have to treat it. The risk is higher if you operate in younger patients. Acromion fracture is a new complication of reverse shoulder because there is too much tension, stress on the deltoid all the time. So the acromion can have a stress fracture. This is the patient of mine who had a reverse shoulder arthroplasty 2 years ago and had been having some aching discomfort. He did a lot of gardening prior to seeing me. And I didn't see much on the doubtful of something in the X-ray. I just did a CT scan. You see a healing stress fracture of the acromion. He's asymptomatic. He's got the movement preserved, so we left it alone. But there are occasions where with the force fall, the acromion can fracture. If that acromion fracture, the outcome is not optimum. There's an occasion where we have to rigidly fix with the tension band wire, double tension band, or a plate if necessary. Glenoid disassembly, we normally take it as a part of the learning curve experience or early experience. One has to see or do at least a 20 reverse shoulder to get a hand of the system because nothing is normal, but we are talking about how to get it normal. So you have to be familiar with the prosthetic system. So how to be safe? We'll just briefly touch base on this. You have to, when you are starter, you have to restrict your use to the cuff tear arthropathy or glenohumeral arthritis with cuff deficiency and move to the further indication as you gain experience. Second, as she's described all this classification, so stay with A1, A2 or B1. The reason is that if you go advanced, then if you need to reconstruct the glenoid, then the complications are higher. Familiarize with the system. There are a lot of systems out in the market, but you have to familiarize with one system first to learn it, processes, and then do the operation. You have a circular or elliptical base plate. Then we have different fixation device. There are some systems with the peg, but currently this evolutive system offers a very stable fixation of base plate with the fin, the triangular fin that holds very good, and then are supplemented by screws. So there are different systems we have to know. The important screws is superior and inferior. The anterior posterior screws are always not possible to put, especially in Asian small glenoid. And you have to use the optimum size base plate for the particular patient. So there are a couple of evolving trends to minimize complication. This is RSA glenoid side development, is lateralization and augmented glenoid. This is the reason for lateralization to avoid scapular notching and increase the stability, increase the shoulder rotation and producing the shoulder contour. So it can be done by metallic or by using a graft. So this metallic and bony lateralization available. This is an example of a bony lateralization to extend the scapular neck in a very severe medialized glenoid. So that's the example, and that is the axillary clearance you get when you use a graft. So if you want to avoid scapular notch, this is the best thing to do is increase the inferior overhang. That is automatically done if you put a larger sphere. So this is what I meant, sphere size does matter. And this is a slide from Dr. Anders Eklund experience of over 1,000 cases. And he talked about his incidence of humeral loosening was around 2%. So this is the rationale for using a short stem, which is also coming in vogue. So this is an example of a short stem prosthesis. So with that, I just close this session. Thank you. And we'll open for some more questions. Yes, Ashish, do you see any questions on the chat box?
No, there's nothing related to this topic.
Okay, one was coming up. How to become member of SESI? You are most welcome.
This is
That's
juicy.
the best question.
That's I like it. You are most welcome. You just my number is there. I will just type it. You can message me or mail me. I will send you the form, the details. You're most welcome.
There's a Telegram group of SESI which has almost 500, 600 members. You can learn from other people by their cases, and you can put up your cases as well on the Telegram group. Chintan Desai is there. I suggest you put up your X-rays on the SESI group, and we'll be able to give you a collective opinion as well on that.
Second question, are you giving fellowship, sir? Yes.
After COVID times.
After COVID times.
After COVID time.
There's a question on tips of glenoid exposure in a stiff shoulder.
Yeah. Actually, the other thing to say that SESI also, we are arranging a traveling fellowship for selected members, and then we are giving a honorary payment as well, honorarium to help the fellowship, and you can visit the center of their choice for 1 to 2 weeks. This is only for SESI members, so that is also in vogue. Yes, Nandan?
Yeah, there is a question on the tips for glenoid exposure in a stiff shoulder. Can I take that?
Yeah, take it.
Basically, the main tips are: one, to release the capsule from the inferior to the head of the humerus. That means the neck of the humerus. Usually, the capsule is attached to about a centimeter below the articular edge of the humerus medially. So, if you release it fully, and sometimes releasing part of the pec major superior aspect also can help. The third point is to do a 360-degree release of the capsule on the glenoid side. Then you will get a good exposure of the glenoid.
Yes, Ashish, your technical tips?
I think good planning, good exposure, and ensure that you are in the plane. In a stiff shoulder patient, when the planes are destroyed, it can get very nasty, and you go down the wrong plane, you're going to struggle the entire surgery. So ensure that your planes are correct. Often the subscap is stuck under the short head of biceps. So ensure you're very careful, not going medial to the biceps at all, just medial to the short of biceps. That helps. And a good exposure, a good healthy cut of the humerus will allow you a lot of nice exposure. But I think where youngsters falter is the exposure of the glenoid. And if you don't have the right instruments, then exposing the glenoid can be a struggle. So you must play around with bones. I know when I visited Jody Bear back in 2006, he used to carry a scapula in his bag all the time. And whenever we had a little bit of coffee time, he used to take out the scapula, and he could talk on scapula for hours together. I've never seen somebody obsessed with a bone, and I realized that obsession is passion. So do a lot of cadaver courses, understand anatomy. That helps.
I think the visitation and fellowship will help a lot in this, because when I was from UK, again, it's about 15 years ago, we were trying to do the total shoulder and the hemi. The main fear is exposure of glenoid. But when you go to France, and I went to see Pascal Boileau at the time, and he was just opening glenoid like anything. And you could see all around 360 degrees with the 5 retractors, 4 5 retractors all around. So your fear is gone, just like that. But the main key is deltopetal approach. I think if you have a stiff shoulder, always use a deltopectoral approach. Yes, Raman.
That's right.
Oh, I am a deltopectoral man. And I'll tell you why.
Yes.
When I was training with Cormac Kelly,
Yeah.
so before me, there was an year 6 registrar who was going to be a shoulder surgeon. Okay. So when I went to Cormac, so one day I told him, Cormac, let's do the superior approach today. He said, Raman, I'm sorry. I said, why? He said, I haven't told you, but I have buggered up the axillary nerve of my year 6 registrar, a future shoulder surgeon, during a superior approach after I have been there for 18 years. So I say no to this approach because even one case will haunt me for the rest of my life. I mean, that was his version, and it was for a fracture situation, right? And then I realized, okay, fine. So after that, he started working on the deltopectoral. Now, Cormac is a complete deltopectoral man. He will not do a superior approach, come what may, because he buggered up the axillary of his own registrar.
Once you
And he picked it up and he sent him to London for microsurgery, right? So I thought that when I came back to India, and there were only two things which Cormac Kelly asked me to do. One was not to do a superior approach. The other was not to do a reverse for first 5 years.
Wise.
Yeah.
One more question. I think how to decide intra-op to mark out the glenoid center drill point. Is there any difference in selecting center glenoid drill hole in TSA or RSA?
Oh, well, so can I take that question on?
Yeah, go on.
So TSA and RSA are like apples and oranges as far as glenoid is concerned. In total shoulder, you are dealing with the whole glenoid. In reverse shoulder, you are dealing with the inferior half or 2/3 of the glenoid. So the markings are different. In total shoulder, you are going for the center of the glenoid, you are marking that. In reverse shoulder, what you do is you are drawing a circle on the inferior 2/3 of the glenoid. So you mark from the inferior edge and then count in millimeters and reach a point on the line and then put your drill bit. Now, as far as this is a very complex topic, you need to be in the center of the glenoid, of the base plate, not the glenoid, but the base plate. And in total shoulder, you need to be in the center of the glenoid because the component is going to cover the whole glenoid.
Elliptical. Yes.
Elliptical. Secondly, you need to be correcting the versions in the horizontal plane as well as the vertical plane. So you need to prevent the superior tail, you need to prevent the retroversion. So it's a whole lot of eyeballing, pre-operative planning on the axial cuts, on the coronal cuts, and then trying to replicate that situation intra-op on the table in the absence of particular jigs and guides that you achieve it right. So this is a lot of practice, a lot of pre-operative thing in your mind and you carry it on the table. So that's the basic difference. And you need to read quite a lot and still there will be hits and misses. But in most of the situations, you will get it right.
I think you summarized everything in detail. I don't think anything to add to that. Go to the question in complicated comminuted fracture of proximal humerus, how to decide whether to go for filos or reverse or TSA.
There have been complete webinars on that.
Yes, there are so much, but I think the main thing is that still our aim, all of our shoulder surgeons or whoever aim should be to reconstruct, to do an osteosynthesis of the fracture.
Yes.
That is our first aim. And in a complicated comminuted fracture patient scenario, if you want to try to fix it, then you always have a backup option of a hemi or a reverse. Yes. In very, very comminuted fracture where you decided already to do only reverse, then it's not a question. Yes, Ashish?
I agree. Of course, there's a major age limitation. You don't want to do a replacement in a 35-year-old. That's very critical.
No.
And it's when the fracture is fresh, even if it's a bad, nasty fracture, you can usually get all the pieces together. And there is too much of a imagined fear about avascular necrosis. It's not such a big problem in the proximal humerus. Exactly. So don't go by the same tenets of proximal femur because the humerus is quite forgiving. There's a good blood supply. And so make every effort.
There are occasions where you just have fractured, dislocated head fragment lying in the axilla for 2 weeks. We have taken it back, fixed it, and fracture is healed without any avascular necrosis for even up to 5 years.
I'll tell you, there's a 20-year-old chap who had a intrathoracic fracture dislocation, and the surgeon just went ahead and in a 20-year-old did a lousy hemi. There were 3 surgeons involved, and the poor fellow failed within 4 months. Once that was done, I was compelled to revise it with a new hemi, but it is never the same. And we've had other intrathoracic fractures. We've removed the head completely, bare shell, put it back in again, and they've healed beautifully. So it's a panic reaction.
A question for Nandan, we'll put it up. Ream and run technique, do you do? What is your indication?
No, for the shoulder, not much of a ream and run. So I think I'll just take out the cartilage and go on to subchondral bone. That's about it.
So the ream and run for the glenoid, I think probably the question is meaning that, isn't it? You do a hemiarthroplasty and then you just ream, make drill holes or ream and then make that cartilage to develop fibrocartilage.
I know that is for hemiarthroplasty, but nowadays where are we doing a hemiarthroplasty?
So the ream and run, are we referring to the eccentric reaming to correct the version?
For eccentric reaming, that's a different, it's not ream and run exactly, but it's more of making
we do that.
abnormal shape thing to reduce, make it more concave. That's it.
More inclined properly.
Yeah. But
what's your limit for eccentric reaming?
Yeah. You should be very careful.
How much retroversion would you accept? What is the threshold for a retroversion to do a eccentric reaming?
Maximum is 15 degrees. I will stop at 10.
10, I think.
So George Jatwal said that 18 degrees is the max because then you'll break the vault.
Yeah.
So 15 is a reasonable upper limit that we can keep.
Because we need minimum 16 millimeter of the vault depth.
Yeah.
So if we go beyond that, we are going to lose the vault. Exactly.
Yeah.
I think with our patients, it should be more on the underside than overside. The biggest problem with that is judging that 10 degrees and 15 degrees is so difficult.
I think we were 15 minutes past the time limit.
Yeah.
Done well.
I think we have answered maximum questions. If there are any burning questions, you can directly contact the speakers. You all know where we are. Thank you, Ashish, Raman, Nandan, for a great meeting. And also thank you, Evolutis, for hosting this.
Thank you.
Thank you, everybody.
Stay safe. Take care. See you soon.
Yeah.
Over to Sudhir.
Yeah. I thank Dr. Ramakant Agarwal, Dr. Ashish, Dr. Ram Chidambaram, Dr. D.T. Nandan. It was a pool of knowledge coming in and a very interactive session, I think, and a very good number of participants we had. And definitely for a few questions which I saw that do we have, what is the best cadaver you have? I think Evolutis is in the process of arranging with all of you all.
When the COVID is down.
Yeah, when the COVID is down. To all the who have attended, yes, there are going to be cadaver labs.
Or you have an online cadaver.
We can try that. If you all are ready, we can do that also.
Okay.
So thank you very much,
Thank you very much.
and thank you. See you soon. Thank you.
Thank you.